Nilesh, you can introduce the next speaker.
Yeah. So next we have Dr. Amar Pujari sir. I don't think he needs any introduction, at least in India. He is a leading innovator from RP Center AIMS. He is currently working as associate professor, and he has multiple innovations, both as new devices as well as improving on the limiting the recent available resources. So sir is going to talk about ASOCT and Strabismus resurgeries. Over to you, sir.
Thank you, Dr. Nilesh. Am I audible?
Yes, sir. Audible and screen is visible.
Okay, thank you, Dr. Nilesh, and thank you everyone at the UC. So today I will be telling what we have done on ASOCT and strabismus resurgeries. So why ASOCT studies are necessary in strabismus? Because basically, as you can see, the retina and the cornea people are much more oriented about the OCT, and they want to see something in the cross-sectional imaging so that they can get some information and they can operate or they can treat the patient. But as far as the strabismus is concerned, you are going to only dissect the muscle. Either you are going to recess it or you are going to resect or placket it. So why do you need OCT here? So OCT can tell something about the muscle location or its thickness or what kind of surgery has been done. So it can basically tell the anterior portion, so up to 6 millimeter of the medial rectus, up to 9 millimeter of the lateral rectus, and up to 5 millimeter of the superior and inferior rectus muscles can be visualized on OCT. In fact, practically we operate on these portion of the muscle, so hence it has some value. So that we want to show that like what are the utility or where it can use this one. So what experts have explored across the globe. So basically, if you get around, if you search the literature, you are going to get around 25 to 30 publications. So out of around 80% have said that they are able to visualize all 4 recti, and they have identified or correlated the normal insertion on OCT as well as intraoperative measurements. But we can do more justice, or we can use ASOCT for more practical reasons in strabismus surgeries, and that is the point when you want to use OCT as a tool based on which you can plan the strabismus surgery. That is going to be key, and that can actually define, or that can do a justice for a strabismus surgeon to buy an ASOCT machine. So previously, normal identification of the muscle has been described. In addition, how we can use ASOCT and what is the stark difference between ASOCT and UBM? Sorry, that has been said. So as I said, we can do more justice if we are able to define the role of ASOCT in strabismus resurgeries. But one thing is, as we have a referral center, so often we are going to get at least 2 or 3 patients per month where like strabismus surgery has been done, but there is no available or documented details. So patient has lost this one and the clinic has lost the details because it could be 10 years, 15 years, 20 years previous surgery. So in those conditions, you can see congenital scarring, you can say some of the surgery might have been done, but you don't know exactly where the rectus muscle lies on the sclera. So you need to identify where the rectus muscle is. If you have some insight, so you can either re-recess or re-resect, or you can adjust in the same eye. Sometimes patients are going to have more than 100 prisms deviation. In those cases, all 4 horizontal recta has been operated. So now you'll be in a very dilemma, like which muscle I need to operate. So that is a tricky situation where you can use OCT to gain some insight. So I wanted to explore the ASOCT role in strabismus resurgeries with lost surgical details or where previous surgical details are completely not available. So it was a prospective interventional study. So preoperatively I did OCT, and intraoperatively there are 4 surgeons who correlated what are the distances I gave it to them. So I took ethical clearance, institution ethical clearance, and patient attending to our strabismus surgery clinic, so for the surgery were evaluated, and those specifically who have lost the surgical details were included. The sample size over a period of 1 year was 10. Till now I have completed 30, but initial 10 included for assessment and publication. And the number of surgeons were 4, and I was the only ASOCT evaluator. So here you can see that the picture A, component A, shows that the medial rectus cross-sectional imaging in case of extreme abduction. You can see this is a thin tendon which is becoming more of a belly here. After 4 to 5 millimeters of the tendon, you can see this is a medial rectus belly. And similarly, you can see on the B component, you can see this is inferior rectus. Again, this is a small portion is tendon which is becoming more thicker or more black. That is your muscle belly. Similarly, in extreme adduction, you can see lateral rectus. Again, the tendon is very thin, and you can see dark belly. And here you can see superior rectus, and superior rectus, of course, it has more of belly, so it is very clearly visible. So this is how the superior, inferior, medial, and lateral rectus appears. So you can just focus here that like the the contour, overall contour of the globe is very convex. It's very crystal clear. You cannot see any bumps here. So it is very well defined. It's like 1/4 of an arc, right? So for just practical understandings, what I said is the scleral or the ocular coat between the insertion and the limbus, let us consider it as an enterocular coat. And from insertion onwards or towards the posterior, let us consider this a posterior ocular coat, right? So here, this is a one example where you can see the larger red arrow shows that there is a slight bump, right? As we know that the sclera is going to be thinnest just behind the rectus insertion. So you can see the thinnest sclera that is depicted by subsequent small arrows, red arrows, and the largest red arrow indicate that probably here was the medial rectus muscle. And you can measure from the angle. So distance was 4 to 5 millimeters. That's what the normal distance is going to be, right? So we are looking for the hypointense area along the scleral coat. It is going to be at the 50% depth, but here I am not able to see anything. So I'm able to see some kind of hypoechoic intensity at 10.8 millimeter from the angle. So in addition, I can see that there's a congenital scarring. So this appearance of the original muscle system bump and the thin sclera and the congenital scarring, all three indicate that yes, probably this eye has undergone some sort of surgery. And where the muscle lies, so probably the hypointense layer lies at 10.8 millimeter from the angle. So I need to compare with the other eye medial rectus muscle. If I'm able to get at 4 millimeter or 5 millimeter, I can subtract 10.8 minus 4 or 5, and that is the amount of recession I'm going to get. Similarly, you can see here, this is another example where medial rectus has been dissected. You can see this is the initial hump. You can see congenital scarring, and there is a thickening of the ocular coat because the muscle has moved anteriorly. And in comparison to the previous examples of normal medial rectus, you can see the medial rectus here, it is quite thick. So it has to be the belly portion rather than the thin tendon region. So again, the distance is 8.4 millimeter. Intraocular showed that there is a stretch scar. So this is how we need to identify the resected muscle. This is for lateral sclera. You can see the ocular contour has completely lost. It has become more of undulating. So this is how when you expose the sclera, it's going to lose its rigidity. It will become more of undulating. And you can see this is the initial bump, the large red arrow. And subsequently, you can see that the ocular coat has lost its contour. And I cannot see a hypointense layer, consistently visible hypointense layer till up to 15 millimeter from the angle. So I need to relocate the LR in the other eye, and I need to correlate where exactly the LR in the other eye, and here I need to subtract that one. So it indicates that probably more than 9 millimeter of lateral rectus has been recessed. And this is for lateral rectus. You can see that the belly, you can note this is not a normal rectus, it is a muscle belly instead of tendon. So it is a resected lateral rectus. So again, I need to correlate to the other eye LR. So if it is a 7 mm and this is a 7.5 mm, yes, probably this is a resected muscle. And with respect to tendon thickness, I can say that this is a belly. So it's a resected lateral rectus muscle. So I evaluated 10 subjects, right? So the mean age of 10 subjects was 23 years, and the mean preoperative ASOCT measured distances was 8.9 millimeter, and the intraoperative distance was 9.12 millimeter. So you can measure within 0.5 difference, right? So you can get a quite agreeable measurements on ASOCT. So to conclude, in strabismus resurgeries with lost surgical details, we can use the ASOCT as a reliable tool where muscle details can be assessed with respect to type of surgery as well as amount of surgery, right? So, but the limitations where it is an evolving tool. I got another publication where they are able to image the muscle cross-sectionally. I mean to say, I was able to image cross-sectionally, but they were able to image in phase. So they were able to see the muscle. They adopted new software. Probably in future that is going to be more common, right? And subject